Welcome, everyone. We'll get started in just a second once we bring everybody into the presentation. Thank you for being patient. Okay, welcome everyone to the Learning and Sharing Cafe for IYCF programming in the context of COVID-19. I'm Brooke Bauer. I'm with the Tech RRT as the Infant and Young Child Feeding and Emergencies Advisor. We have Ben and Rita also with Tech RRT behind the scenes providing admin support. If you can, please introduce yourselves in the chat box. The chat box we will use here for general discussion. And the Q&A box for specific questions. So some questions in Q&A will be live answered, and the rest will be compiled and answered in the Q&A section. This webinar is brought to you today by the Tech RRT, UNICEF, the IFE Core Group, the World Food Programme, Save the Children, Helen Keller International, International Medical Corps, the John Snow Inc., USAID, and the Global Nutrition Cluster Technical Alliance, formerly known as the GTAM. There'll be a quiz and survey at the end, and this is just a reminder that this webinar will be recorded. Next slide, Rita. We're very grateful and thankful to our donors for this webinar. It's made possible by USAID, CEDA, IrishAid, Save the Children, and UNICEF. And while it was made possible by their generous support, the contents are responsibility of the Tech RRT and individual partners, and they do not necessarily reflect the views of these donors. Thank you. Welcome.
Thanks so much, Brooke. Good morning, good afternoon, and good evening to everyone. My name is Linda Shakir Berbari, and I am the IFE Core Group facilitator, Infant Feeding and Emergencies Core Group facilitator, which is a collaboration of organizations, agencies, and individuals, basically aiming at supporting and promoting and protecting infant and young child feeding in emergencies. So I will continue from where Brooke started off and hopefully go through this hour and a half for the Learning and Sharing Cafe. So it's going to be a cafe, meaning that it's a bit loose and meaning not very formal, and really an opportunity for all of us to listen into the experiences of organizations on how they are adapting to the COVID context in terms of their infant and young child feeding programs, and also to emergency contexts. So the objectives of this cafe, really, as I said, is to create this platform for sharing and learning, and really to listen to these experiences, because eventually we all aim at supporting and promoting and protecting infant and young child feeding, and making sure that infants and young children and their mothers are protected, and that morbidity and mortality is decreased and the risk is decreased. The second objective for this cafe is also to reflect on how global guidance have really helped us and have been used in inspiring and guiding these adaptations. So many resources are out there, and the previous cafes, which I invite you to look at if you haven't been attending, the previous cafes are currently online on the Tech RRT website, where we have two really good presentations to present all these guidance, and of course these are present on different platforms. So that's the second objective, and the third objective is really to encourage all of us to how small or how big our organization or initiative, to really share our ideas and share our adaptations and experiences, so that we all learn from each other. Next, please. So our webinar or cafe, can we move next, please, the slide. Thank you. Today we were just going over the objectives. We will do some introductions on who will be presenting today. And so we've got 3 case studies. We've got 3 examples. One is from Nepal on IYCFE to strengthen IYCF practices during COVID-19 in Nepal. And the second is on adaptations to routine IYCF activities in Jordan, also as a response to COVID-19. And the fourth is from Kyrgyz Republic, the adaptation of nutrition programming for COVID-19. Then, since this is a cafe and it's custom that we do games, so we have a small interactive game that we encourage you to really stay to participate in, so that we can reflect on some of the things that we've been listening to. And of course, a very important part, which is our sharing and questions and ideas that we want to reflect on. And so please, I encourage you not to be shy and to put your questions in the Q&A chat box. So you've got a chat box, as you can see in the Zoom box. So there's a chat. This is where you can introduce yourselves. But I encourage you to please put your questions in the Q&A box. And if you see questions that you agree on, please, you can just click on the thumbs up for this particular question, so that you can, put more emphasis on it, so that we can also highlight it. And during the period of the questions and answers, we can ask it. Finally, and very importantly, the last section of the Café is the evaluation, recommendations, and closing. We really urge you to really fill out the evaluation. There are 2, basically there's a small survey to really understand what you've been doing, and then there's the evaluation for this webinar or this cafe, so that we learn again how we can improve on these experiences. So without further ado, I will proceed with the introductions of the organizations and individuals who will be presenting. Next, please. Yes. All right, great. So before we go through the presenters, let me just reemphasize what Brooke mentioned, that we've got TYCF, Rita, and Ben behind the scenes, really doing an amazing job. And we've got 3 very talented interpreters and very adventurous interpreters for 3 languages, in Arabic, French, and Spanish. Geralda Madi and Elsa Sarkis for Arabic, Joanne Jamous and Christiane Noon for French, and Ana Diaz and Carla Dongo for Spanish. So if you would like to listen in on the interpretation, I think you just have to click on the language, and then you can hear the different interpretations. And we will try to speak slowly, so that their job is easier, and so that you can enjoy the presentations. I think Brooke was introduced already as an IYCF advisor for TYCF, and I also introduced myself. So I'll give the floor to Beam from Nepal to introduce herself.
Thank you, Linda. Hi, this is Beam from Nepal. I am working with Helen Keller International Nepal as a senior program manager in Suhara 2 project. Thank you.
Thank you so much, Beam. I will give the floor now to Ruba Abu Talib from IMC Jordan.
Hi, my name is Ruba Abu Talib. I'm the Nutrition Project Manager for the International Medical Corps, Jordan.
Welcome, Ruba.
Thank you.
Moving into Dr. Nazgul Abbasbekova from Kyrgyz Republic. If you would like to introduce yourself, Dr. Nazgul. Yes.
Hi.
Hello.
My name is Nazgul Abbasbekova. I am Chief of Party of USAID Advanced Nutrition Project in the Kyrgyz Republic.
Welcome. And last but not least is Alessandro Yalamo from Save the Children and from the IFE Core Group. Alex?
Hi, Linda and everybody. Yes, you mentioned it's Alex. You can call me Alex, Global Advisor on infantile and child feeding in emergency for Save the Children, and very delighted to be here and a fantastic group behind the organization of these cafés. That's all, and all the best to the presenters and to all of us. Over.
Thank you so much, Alex. I think we can then proceed with the presentations. Just flagging here, there's a comment around interpretation. If you continue experiencing anything, please do send a message to the panelists. There's an option also to send a message to the panelists if there's any logistics that you would like to flag. I will give now the floor to Beam, and 15 minutes, hopefully, Beam, and I'll be following up after that. Please go ahead.
Thank you, Linda. Welcome to all in this cafe. Now I am going to talk on case study to strengthening the IYCF practice during the COVID in Nepal. Next slide, please. Next slide, please. Yeah. Most of you know that Nepal is the landlocked country. Regarding the COVID, the first case was COVID was confirmed in January 2020. You can see the current situation of the COVID in Nepal. After 4-month-long lockdowns, still the COVID case is continuing increasing. All school and college are closed still, and from the COVID, more than 1.2 million under 2 years children are affected, and additionally 60,000 children estimated to be at risk from the wasting. Next slide, please. Next slide, please. Yeah. With some brief background information on IYCF indicator in pre-COVID, we all see that the IYCF practice are still low. Regarding the exclusive breastfeeding, we have the 66%, but this exclusive breastfeeding is declining with increasing the age of the children, and the minimum dietary diversity and acceptable diet also diet are improving with increasing the age of children. Next slide, please. Yeah. Now, in this slide, I am going to talk a little bit about our Suhara 2 program. It is the multi-sector nutrition program funded by USAID, and the project is covering more than half of the geographic coverage. You can see that here dark blue are our project area, and the project aims to reach the 2 million women and children. Next slide. Yeah. Some of the IYCF program pre-COVID used to happen in, we have the home visit. In home visit, we are doing the interpersonal counseling, engaging the household members, all household members, using the using the BCC materials and job aid. And another is we have the community level interventions. Next, please. Next, please. We have the community level. We do the key life event celebration, the starting of pregnancy and delivery, and a child turning in the 6 months of age. We also do the cooking demonstration at the Health Mothers Group meeting. The meeting is led by the community health volunteer, and all this platform we do the MUAC screening. Next slide. Next, please. Yeah. Next. Yeah, we have another is the BCC, mass media and technology. We have very common or famous weekly radio program we call the Banchinama program. We have also promoting the IYCF message and behavior from the different social media. Next slide, please. Yeah. Yeah. Due to the COVID, IYCF programs were disturbance, challenges, and we have the next slide, please. Can you do the click all slide? Yeah. Yeah, we have the national because mobility restriction because of the lockdown that affected the ongoing in-person IWC BCC intervention and service seeking trend, and also nutrition health service distribution, that is the GMP and other programs. We have also postponed the national vitamin A distribution supplementation program that times. Also in community, some of the community we have still the myths and the misconception about the around the COVID and breastfeeding that increase the risk in breastfeeding continuations. Next slide, please. Yeah, we had some of the IWC program implementation and adaptation in the we adopted the IYCF guideline in the country context that recommended by WHO with the leadership of the government and the other EDP. Jointly, we developed the IYCF interim guideline and IMM interim guidelines. And also, we revisit and modified our existing SPCC materials and developed the frontline job in the context of COVID. We also printed all materials and distributed widely to the frontline workers in the community. And also our interpersonal counseling approach, we changed from the in-person to remote counseling, and we accelerated and diverse our social and mass media, and also we did the capacity building of the frontline workers on IWCF in the context of COVID by using the modern technology. Next slide, please. Yeah. Program after adaptation, we can see here the reach of the programs from by different activities, adaptation activities. We succeed to we able to reach the more than 4 million people from the different activities, and we have also developed the one video on breastfeeding, short breastfeeding on COVID, targeting on breastfeeding in the context of the COVID, targeting to mothers and the health workers. Next slide, please. Yes.
आमाको दुधबाट
Yeah, this slide or this video was one minute video targeted to the 1,000-day models and frontline workers. I already mentioned it. Yeah. Thank you. Next slide. Yeah. What are the enablers to adopt and reach the? We have the Suhara program have the good foundation at ground levels and the good network with the frontline health workers. So the one of the enabler is the existing system of the Suhara 2 programs. Another is the we have good coordination mechanism with the government at different level. So last one is the modern technology, access of the modern technology and optimum use of the technology. So this three we mainly we highlighted here. This is the treatment where the enabling for the programs. Thank you. Next slide, please. Next slide, please. Yeah, What is the working well? Of course, the intensive telecounseling and frequently work follow-up. And also, Suhara has already have the multi-sector approach. So the multi-sector approach also make the well to work, and we have the comprehensive monitoring system to inform the program. And we do the intensive and diversify SPCC and social media promotion. And some place we also do the in-person counseling with infection prevention measures. Next slide, please. Yeah, we have also some challenges when adopting the IYCF program in the COVID context of COVID. I already mentioned that we are using the modern technology in our program, so we have the some challenges to cover in the remote area. And also there is the risks of the infection to our frontline workers. To overcome this, we supply the PPP to the staff and even the female health volunteer of the project area, and also reinforce prevention measure from the multiple channels, including the all IYCF curriculums. And we made the mandatory to use the masks and hand washing in the different all events. And also range of we have the challenges to range of our intervention from the household to community level, because the onset of the COVID is almost like 8 months over. So that is we have the challenges. So we use to respond to these challenges, we use the maximum use of the telecounseling and remote follow-up and household health facility. And another is the context changing every day. So we have been reviewing and revising our strategy approach as for the context of the situation. Next slide, please. Yeah, here is the short clips of the models who participate in the adaptation of IYCF programs. Please.
नमस्कार, मेरो नाम अन्जु गुरुङ, मेरो घर गङ्गा जमुना गाउँपालिका वार्ड नम्बर 3 साबी गुम्ती 3 छेलाङ। म यो आहारा कार्यक्रमलाई म धेरै धन्यवाद दिन चाहन्छु, किनकि उहाँले मलाई जुन हुनुहुन्छ पूर्णिमा म्याम, उहाँलाई धेरै धन्यवाद। उहाँले गर्दा नै मलाई आज यस्तो राम्रो हुन पाएको छ, किनकि उहाँले मलाई जब म उता काठमाडौँ हुँदाखेरि म प्रेग्नेन्ट अथवा गर्भवती अवस्थामा थियो। त्यस्तै अवस्थामा आएँ, म आउँदाखेरि लकडाउन भइहाल्यो। लकडाउन भएपछि म उता पनि जान पाइनँ, मेरो चेक जाँच सबै उता भइसकेको थियो, आइरन चक्की र क्याल्सियम सबै उता खाइसकेको थियो। अनि आएपछि चाहिँ म यतै उहाँले चाहिँ मेरो बारेमा थाहा पाउनु भएछ, म यस्तो अवस्थामा छ, म गर्भवती अवस्थामा छ भन्ने कुरा उहाँले थाहा पाउनु भएछ। त्यही भएर उहाँले मलाई कतैबाट कन्ट्याक्ट गर्नुभयो र उहाँले कन्ट्याक्ट गरेपछि म हो भनेर सल्लाह भयो, उहाँले पनि सल्लाह दिनुभयो र त्यसै गरी महिनैपछि उहाँले मलाई हेल्पर्स जानुहोस्, चेक जाँच गर्नुहोस् भन्ने सल्लाह दिनुभयो। अनि चेक जाँच गर्दै फेरि पछि चाहिँ मेरो डेलिभरी समय हुन लाग्यो। भएपछि उहाँको लकडाउनको बेलामा पनि एकदम गाडी चलेको थिएन, बिजुक थियो, त्यतिखेर उहाँले नै गाडी खोजिदिनु भयो, अनि हेल्परसम्म पुर्याइदिनु भयो। अनि पूर्णिमा म्यामले भन्नुभएको थियो बच्चालाई कुन आकारमा बसाएर दुध खुवाउने भनेर, उहाँले चाहिँ सी आकारमा बनाएर दुध खुवाउनुपर्छ भन्नुभएको थियो र एउटा दुधलाई 15 मिनटसम्म चुसाउने र अर्को दुधलाई पनि 15 मिनटसम्म चुसाएर खुवाउनुहोस् भन्नुभएको थियो। अनि त्यसै गरी 6 महिनासम्म चाहिँ पानीको पनि नखुवाउने, सिर्फ आमाको दुध मात्र खुवाउने भनेर सल्लाह दिनुभएको थियो। धन्यवाद।
Next slide.
नमस्कार, मेरो नाम अन्जु गुरुङ।
We have some lesson learned from this adaptation IYCF programs. Please. Yes, you can do it. Yeah, we have some lesson learned. We have already We have the in our program we have the update information from the household level, so it makes easy to smooth transition from in-person to remote phone-based intervention in the context of COVID. And another is we are maximum use of social media, and we in this media we give the space to put the client views, respond, and concern. From that that help in the standardize and updating the message and prioritize the interventions, and the message complemented by the diverse media and effective idea for transferability. We have the only two ideas that we can transferability. One is the telecounseling and phone-based follow-up, because we in the context we are in the COVID context we use the maximum telecounseling. It was found very effective and high coverage. Even after COVID, we have the plan to do the continue of the telecounseling and the phone follow-up. And another is the message in the local and diverse language. So these two are the idea for transferable. Thank you. Next slide, please. Thank you. Thank you.
Thanks so much, Beam. This is really fascinating. Thank you so much. Especially, it's interesting how you already had some form of remote support, and then you expanded on it, and also the collaboration you've got with the government. So thanks so much. I'd like to encourage everybody to ask questions, more clarification, the how-to, and you know, especially that last part about adaptability and transferability. I think now we will move to our next presenter. Next, please. Ms. Ruwa Abu Talib, the floor is yours.
Yes, thank you. Can you hear me clearly?
Yes, we can.
Yes, that's good. Good afternoon, everyone. It's afternoon here in Jordan. Today, I'm gonna just take a few minutes of your time just to display a few adaptations that we approached during the COVID-19 pandemic in Zatari and Azraq camps in Jordan. Those are the camps that are officially hosting Syrian refugees in Jordan. Next slide, please. Next, yeah. Now, before going through the presentation, I just wanted you to see the location of those camps, relevance to the capital of Jordan, Amman. Zatari camp is 73 kilometers northeast. It's closer to the Syrian Arab Republic, and actually Syrians started to come on foot from Syria to the Mafraq governorate where Zatari camp is located. It's the first camp for Syrian refugees in Jordan, and it was open officially in July 2012. The other camp is Azraq camp, is 110 kilometers eastern Amman. It was officially opened 18 months after the Zatari camp. Next, please. The Zatari camp, as it is the first camp for Syrian refugees, it's more heavily populated than Azraq camp. As you can see, this is the demographic distribution of women, of men, women, boys, and girls in Zatari and in Azraq. As you can see that the ratio of
el ratio o la razón.
Well, I'm sorry, I can hear the interpretation.
Puedo escuchar la interpretación, lo lamento.
Is it possible that?
Es posible que
Yeah, okay.
Now
the ratio of men and women, the ratio of men and women to boys and girls is relatively equal for all age groups. Now the total population. The total population for Zatari camp is 77. No, please go before. Yeah, the total population for Zaatari camp is 77,771. The estimated infants and young children figure is 13,687, young children 0 to 59 months. For Azraq camp, the population is 41,577, and the estimated figure for infants and young children is 7,317. Next, please. Okay. Now, because we do not have updated interagency data from latest survey, the latest survey that we have was performed in 2016. This table shows you the
Esto muestra solamente datos del 2016. Esto muestra los porcentajes de las prácticas para alimentación de lactantes niños pequeños correctos para niños entre 0 y 23 meses de edad. Solamente necesito identificar algunas de las
31 for Azraq camp was 450.
Para el campo, y los números fueron de entre 400 y 500 niños evaluados en cada campamento.
Ruba, just hold on 1 second, please.
Yeah. Now, what's important for you to understand in this table is that the way by which we approached those people for it was by random screening, shelter to shelter visits. We can go to the next slide. Okay, now for this slide and the slide after this, I just wanted to demonstrate latest data that compares the rates for utilization of nutrition and IYCF clinics in Zaatari and Azraq camps before and after the COVID-19 pandemic. Now, these are the indicators for which we measure the success of our IYCF program. As you can see, there's not much big difference of the percentage per se for the rate of exclusive breastfeeding before and after COVID-19. But what you can notice significantly is the drop and the significant reduction in the utilization rates of people coming to the clinic and approaching IYCF clinic for IYCF services and support. Now, this can be attributed to the fact that people are trying to avoid crowded places and somehow are conservative and afraid to catch illness or disease from health units. We can go next. And also I have, I said for the slide before and the slide next, this is the same. You just can notice the reduction in utilization rates. This is for Zaatari camp. Next, please. Now, the practice for IYCF before COVID-19 was as this chart shows. Our relationship with mothers starts by the minute she knows she's pregnant, and she starts following up with reproductive health clinics. We have good cooperation with reproductive health colleagues so that they refer those mothers to nutrition clinics to receive all what they need to know about maternal nutrition. And in the latest pregnancy phases, they are referred to our clinics to receive practical training on how to support the early initiation of breastfeeding and the benefits of exclusive breastfeeding. Now, after a mother passes the first assessment in postpartum, I just need to highlight here that all midwives in both camps, they received good training to support mothers to initiate breastfeeding within the first hour after delivery. So this is
una buena atención justo
So sorry about this. Maybe I just, Ruba, just in case when you hear the translator, maybe you can pause. Apologies for all. It seems that there are some technical glitches. Usually this happens smoothly, but for some reason today the translation is, you can sometimes hear it. So apologies for that. Ruba,
it's okay. Yeah, okay. As I mentioned, that all midwives in delivery clinics inside the camp, they received good training on how to support mothers to breastfeed within the first hour after delivery. After the mother passes this first assessment, she is supported by our teams, either the community nutrition volunteers or the nutrition counselors. A mother is invited to the clinic to support the breastfeeding and to receive the proper counseling on exclusive breastfeeding and other phases of IYCF program. Now, in case a mother has challenges in applying IYCF steps or in breastfeeding her son, her baby child, okay, this mother remains followed up by the IYCF counselor until the challenge is resolved. If the challenge is not resolved, then there might be some need for medical intervention, and she might become eligible, either herself or her baby, eligible for milk formula prescription. Now, milk formula is provided according to strict SOPs, unified for both camps. And it's part of our IYCF program is to provide the formula milk safely for eligible children. Here below, you can find that we do provide exceptional milk formula for children with special metabolic disorders who are unable to breastfeed or consume regular milk formula. Now, while the IYCF program passes through those different phases, there's an ongoing activity being done at the level of the community by the community nutrition volunteers who support mothers with breastfeeding without challenges. So that we want them to sustain this activity. We want them to introduce complementary food on time. We want them to sustain breastfeeding till the end of the 24th month. This is done at the level of the community, shelter to shelter visit by community nutrition volunteers. Now, while they are doing their regular follow-ups, in case any mother with a challenge pops up, they refer her to the nutrition clinic for support by the counselor. Next, please. Now, once the alert of COVID-19 started in Jordan, that was early in March 2020, we did not have this number of cases. There were only 2 confirmed cases by mid-March, but the caseload increased rapidly within the 2 days afterwards. Then the government announced official curfew and official procedures to decrease the movement and to avoid crowds of people and gatherings. So the point or the main challenge that we had here is that our staff, because we are not medical staff, we are health staff, nutrition counselor, we did not receive relevant permits to enter the
no recibimos permisos para
that's why we had to let's say we had to become creative and manage the program remotely. This is challenging because usually a nutrition program needs is based on communication and supporting mothers practically. What we before going through to what we did, just continuing with the challenges. We have also local pharmacies selling milk formula inside the camps. While we were inside the camp, we had this controlled. We controlled the purchasing of formula by mothers inside the camp. But in the absence of nutrition counselors, people were procuring the milk formula, which increased the number of cases coming for relactation after the COVID-19 curfew. Another challenge was that primary healthcare centers were not operating at full capacity in Zaatari and in Azraq camps. They were only responding to emergencies, which increased the risk of having individuals falling into malnutrition, children falling into malnutrition, and mothers falling with deep IYCF challenges and unable to find proper assistance. We can go next, please. Now, the adaptations that we had to come up with is to build on the existing relationship that we have with our colleagues from the reproductive health department and the pharmacists. The link was established by the community nutrition volunteers. They supported the mothers following up for IYCF. They reached out to them and they coordinated with the midwives from RH and pharmacists in case a mother needs a milk formula prescription. Now, the midwife is responsible for the breast assessment if the mother is eligible or the baby is eligible for milk formula. Then the case is referred to the pharmacist to dispense milk formula. Another adaptation was basing a community nutrition volunteer within the primary healthcare centers, even not IMC primary healthcare centers. Now, this approach allowed the community nutrition volunteers to look for and screen for IYCF needs and nutrition needs among individuals coming, mothers and children coming to the clinic requesting health assistance. We can go next.
Excuse me, Ruba, 4 more minutes, please.
What?
4 more minutes?
I think I can manage that. Another adaptation was that because we have 21 volunteers per camp, so what we had to do is to just limit the rate of personal error. So we had only 2 volunteers per camp deployed to manage the cases of severe malnutrition and the IYCF cases with challenges, particularly mothers receiving milk formula. This means that either these two volunteers are either rotating around the camp, different clinics, or are based at one location and people are coming to them to receive the needed assistance. The 4th adaptation was the family MUAC. The family MUAC is the empowerment of caregivers to screen malnutrition for their children. If you need information about this, I can forward that to you. Let me just focus more on IYCF adaptations. The working remotely adaptation, because we did not have entry permits, we had to manage the support from the health co-workers by facilitating Microsoft Teams trainings outside working hours to provide proper orientation to our colleagues from other health departments so that we can sustain the smoothness of IYCF program in the camp. We managed remote communication with the community nutrition volunteers and remote supervision. And then the peer support groups were done via WhatsApp groups. There's a video afterwards. It can clarify more what we are doing with these support groups. We can go now. Next. The main challenges that we had as we were implement those adaptations. First, the level of education of community nutrition volunteers, because the knowledge they have gained it by practice. They are unable to respond to new cases. That's why we cannot rely on them 100%. This was challenging. We needed the support from health teams. We had limited staffing on the reproductive health projects during the curfew. That's why we had to divide the cases on different days, and we had some kind of logistic issues about that, but all ended nicely, and we were able to overcome the challenge. Part of the refugee community in camps does not trust community nutrition volunteers to deliver the nutrition services. That's why we had defaulters not willing to come to the clinic, or not willing to host community nutrition volunteers whenever they come to their doors. We had to manage with those defaulters once we stepped back into the camp. We had an interrupted electricity and internet connections at the shelter level. That's why we had our volunteers just not unable to show us photos from the shelters, but they immediately they were moving back to the facility to send the photos or share the videos. But the communication via mobile phones was running perfectly. Also, the private pharmacies, I mentioned this challenge earlier, they were selling the milk formula inside the camp, which increased the relactation cases after we stepped back into the camp. Next, please. Now, the enablers of implemented adaptations, actually, this is inspired by UNICEF approach to Syrianize the programs in camps. We started by early in 2020 to rely more on the community nutrition volunteers, and we provided the specialized training for them. So they were able during the curfew to maintain good cooperation with pharmacists and midwives. We received good reporting and communication from them, and they had all needed working ethics so that they were able to reach out to all mothers early in postpartum. We had good electricity and internet connections at the facility level. The curfew inside the camp allowed or let's say prevented the virus spreading. Gatherings were not allowed. Distributions were not allowed. Agencies doing baby kit or hygiene distributions were doing it shelter to shelter. Nutrition counselors communicated remotely with all pediatricians to support exceptional milk formula cases, and the proper interagency coordination held by the UNHCR chair in each camp was quite supportive to enable the implemented adaptation. Next, please.
Ruba, it's good if we can wrap up final slides. Thank you.
Can we just show the video? It's only 1 minute.
Yeah, sure.
Okay, you can read this, but please just step into the video after this. Yeah.
يعطيك العافية أنسة وفاء. بس بدي أسأل سؤال. أنا ابني بالأول كان بيحب ياكل الباكيتات وبياكلهم منيح، بس هلا حسيته من جديد صار يجفص وصار يعني بيمل من الأكل الحلو.
هلا بالنسبة لموضوع الباكيتات، إشي طبيعي الطفل بعد فترة يبلش يمل منهم أو يزهق، لأنه بصفي عنده زي روتين يومي. هون بيجي إحنا دورنا إنه ننوع ونخلط الباكيت مع أي أكل ثانية، سواء مثلا من أكل البيت كنت أنت طبختيها، إذا ما بيحب الحلو نحطه له مرحلة الملل.
يعطيك العافية أنسة وفاء، إن شاء الله راح أتبع النصائح اللي حكيتي لي إياهم إن شاء الله.
بس بصراحة صارت معي مشكلة هالكم يوم مشان ابني. ابني عمره 4 شهور، وبصراحة كثير على طول عنده نفخة، يعني عم بعطيه كمون بصراحة.
اسمه بتوضح إنه بنخيرها مع بعض كأنها بطن الطفل، وسميت الصفحة الرسم بعنوان تجنب أمعاء الأطفال لما بيصير نقص شديد أو نفخة ممكن توصل لمرحلة البالون المنتفخ اللي يتفجر من الوجع. كيف يعني؟ هلا زي ما انتم شايفين هون احنا عندنا الساعة بتمشي هيك، عقارب الساعة بتمشي بشكل هذا الاتجاه. هون عندنا السرة، الغازات تمشي كيف مع عقارب الساعة. أنا بدي أحرك حوالين السرة عكس عقارب الساعة عشان تطلع من فتحة الشرج تكون الجهة هاي تمام. فأنا بحط شوية زيت على الأصابع هدول الاثنين.
Okay, this just shows the IYCF and CMAM lessons learned after the curfew. I just wanted to highlight the importance of remote training and remote communication, utilization of on-the-job training, and maintaining the WhatsApp support groups. This figure is a figure of on-the-job training of a nutrition trainer explaining the 10 steps for a baby-friendly hospital to a gynecologist. Once she's done, she hangs the poster against the wall with proper contact information so that the agency can contact us in case for future training needs. And thank you. That's it.
Wow, thank you so much, Ruba. This has been really fascinating and a lot of learning, and you know, especially how things have evolved with you, how you managed to change even specifically for the artificial feeding support, for the remote support. Really fascinating. Thank you so much.
Thank you.
And to highlight also, you highlighted at the beginning also the, you know, how utilization dropped. And this is exactly why these learning experiences are important, because this is what we, you know, these are some of the consequences that you're highlighting in the COVID-19 and sharing how we can really adapt our program in order to overcome these challenges. So thank you so much. And apologies again to everyone who has been enduring with us some of the challenges of the translation and interpretation. Thankfully, it's all going well now. Now, without further ado, we will move to our last learning cafe, which is the experience from Kyrgyz. Over to you, Dr. Nazgul.
Thank you. Thank you very much. Greetings from the Kyrgyz Republic, and I'm going to share with the adaptation experience of Kyrgyz team of Advancing Nutrition Project. Next slide, please. The Kyrgyz Republic is a lower middle income country located in Central Asia, as you can see on the slide, with population 6.5 million. Country has wide coverage of health services, almost universal access to primary education, basic sanitation facilities, and electricity. The country allocates more than 10% of its budget to health. Although this public spending seems high, spending in absolute terms is still low due to the low GDP base. Mountainous terrain and harsh winter climate also create challenges to availability and access to certain types of food for nearly half of the year. There is also considerable disparity in the standards of living between rural and urban areas, and women are generally limited in participation in decisions about intra-household distribution of resources. Project is working in 2 out of 7 regions of the country. We call them oblasts in Jalalabad and in Batken. The goal of the project is to improve nutritional status of women of reproductive age and children under 5 with a focus on 1,000 days of window of opportunity. To achieve this goal, we are working through 2 objectives, and I will highlight them in coming slides. All project activities are being conducted in partnership with national and local government and health centers, village health committees, and local and international non-governmental organizations. Next slide, please. The country has made significant progress in reducing child mortality and was able to achieve MDG 4. However, progress reducing malnutrition has been more modest, with the 2018 mix showing stunting level among children under 5 at 12% nationally. More than 80% of mothers report initiating breastfeeding in of their children within first hour. But according to the survey, only 46% of children up to 6 months are breastfed exclusively. And the median duration of exclusive breastfeeding is just 2.2 months. 60% of children under the age of 2 receive the recommended number of food groups for their age. The situation is particularly dire in Afghan Oblast, with only 1 in 10 children receiving a minimum acceptable diet. Next slide, please. Project started its operation in February of this year. The first cases of COVID-19 were detected in country in mid-March. Authorities introduced lockdown of the entire country and declared the state of emergency for almost 2 months of period, which is closed almost all businesses and government offices. No travel within the country. Walking was allowed only in a radius of 2 kilometers from the place of residence. Our staff members are working from home and continue to engage with each other and partners remotely. These conditions resulted in the delay of many project activities. According to government, this time should be used for preparing to adequately respond, to extend beds in hospitals and procure needed medicines and supplies. Unfortunately, lockdown time period was mismanaged. In May, government eased lockdown conditions because of economics lost. In mid-June, we experienced a terrible increased peak of COVID-19 infection, causing high level of morbidity and mortality. And today, unfortunately, we see the repetition of those days. COVID cases is growing rapidly again. On this slide, you can see the current situation. Next slide, please. A lockdown sharpened many of existing socioeconomic challenges in the country. Thus, 22% of population who are poor became more vulnerable in spite of more than 40 million USD of international aid for fighting COVID. The global pandemic in Kyrgyz Republic, complicated with unstable political situation. The recent flawed parliamentary election were exacerbated by unrest, which resulted in a power change, resigning of the president, and new election were called. Next slide, please. As I mentioned earlier, the project has 2 objectives. First, reaching target communities through SBC approaches, building knowledge and motivation around the promoted nutrition-related practices, and increasing demand for nutrition services through various platforms such as community and urban outreach, home visits and community meetings, TV and social media. And second objective is working to improve the quality of nutrition services provided by health system at the primary and secondary level, and to advocate for improving policies and guidelines at the national level. Next slide. The project has adapted its SBC and training strategies and platforms to continue and strengthen programming during COVID-19 pandemic. On the left side of the slide, you can see our typical approach, which involves training of volunteers. We call them activists, on a different nutrition and hygiene topic each month. Those activists then engage with their communities through targeted household visits and community meetings. The home visits would typically be conducted in person, but the project has adapted its approach due to the COVID-19 pandemic to reach households virtually. The project team adjusted rural outreach to take place online, trainings online, and virtually recruited around 1,000 community volunteers in Batken region. And activists received an orientation on social mobilization virtually that was followed by training on nutrition topic. For each training, 5 to 20 participants will engage for 1 hour module via Zoom. With each session, activists received job aids on module in kind of educational animated video and infographics via WhatsApp. Following these trainings, activists will conduct virtual home visits to 1,000 households via WhatsApp. And then activists received mobile phone credit to cover their time spent conducting these visits. Providing of these credits became possible as a result of rebudgeting of projected transportation costs. Next slide, please. Adaptation of health professional trainings. As a first step, pool of national and regional level trainers was developed to ensure that the training resources are in place and to assist the rollout of IYCF trainings in the regions. Each virtual training has 15 participants who engage with the content via Zoom for 3 hours a day for 3 days. Prior to each session, participants receive reading assignments via mail or WhatsApp, including the Kyrgyz Republic adaptation of the IYCF counseling package when COVID-19 is suspected or confirmed. You can see the cover page of that brochure. During online health professional trainings, the possibility of practice, unfortunately, was excluded. The project found an opportunity to fill this gap by conducting post-training follow-up and virtual supportive supervision from trainers to ensure that these trained health professionals have retained their knowledge content and have a chance to practice their counseling skills and receive feedback. The project is working through peer mentors to encourage the use of supportive supervision tool to reinforce learning and skills on an ongoing basis. Next slide, please. Despite these challenging conditions due to pandemic, the project made significant progress in moving forward with activities and was able to complete most of the important deliverables. Enabling factors are highlighted on the slide. These are a high literacy rate of the population, good coverage by health services and mobile phone ownership and internet coverage, support of Ministry of Health and existence of network of community volunteers known as village health committees in almost every village who served as an entry point for the project to expand and strengthen these groups. Next slide, please. Among the challenges we met was that health system overwhelmed and struggled and was struggling to cope. During the lockdown routine well baby check, including immunization and antenatal care visits to health facilities were limited, allowing only emergency cases. Hand washing practices and wearing face masks were poorly adopted by population. Adopting online communication accompanied by both technical and psychological difficulties. This has also caused difficulties in receiving feedback from target communities. Next slide, please. What works well? New conditions allow us to explore new channels and opportunities in delivery of our SBC activities and health system strengthening activities. Changed perception of virtual communication to positive and allow us to build stronger communication and advocacy plan at policy level. For example, National Postgraduate Education Facility focused on equipping and strengthening online in-service training system. And next slide, please. Here on this small video highlighting perspective of from communities. Can you please on this?
USAID'тан каржылоосу менен муктаждандыруу долбоорунан Айсул жеңем бизге жалаң гана эмчек эмизүү боюнча темасын бизге өттү. Мен жашым 21-де, мен балам азыр 2 айлык, жалаң гана 6 айга чейин эмчек эмизип гана багышым керек экен. Эмчек эмизүүнүн артыкчылыктары көп экен. Биз коронавирус учурунда дагы баланы эмизип беришибиз керек экен. Бирок колдорубузду сандап чугуп, маска менен гана эмизүү керек экен. Сиздерге чоң ыраазычылыгыбызды билдиребиз. Чоң рахмат.
Men dagı ADK'nın müçösü bolup işleymin. Uşu özüm nevремди эне sütü boyunca ötkөн sabaktardan жақшылап қарап, келиниме қаралашып, жатам, чоңойтуп жатабыз. Şu ADK'нын немелерге терең ыраазычылык билдирем. Рахмат сиздерге.
Thank you. Next slide, please. Our main lessons learned and ideas for future. The critical inputs for success was strengthening skills around the use of technology by target communities, having access to mobile and internet connections, and keeping connection with target communities during emergency is really critical. For future, we think that continue online connection in combination with in-person meetings will be essential. And we will prioritize in our program development of effective dissemination materials. And this is also very important to continue to improve adaptation of programs to emergencies. Over. Thank you very much for your attention. And I will be happy to answer to any questions you have.
Thank you so much, Dr. Nazgul. This is really interesting. Especially caught my eye the supportive supervision that you also were mentioning in these circumstances, and for including it. So thank you so much, and such heartwarming also videos. Thanks so much for sharing these experiences. A number of questions in the Q&A, and so however we will hold on to that. We will now move to a interesting section, which is the quiz, and I will now hand over to Brooke to facilitate that section.
Great, thanks, Linda. And thank you to all the presenters. That was really, really great. So now we will do a quiz about the presentations that we saw. Rita, if you can put up the first question. You can click on your screen. What was an important enabler across all three projects that we saw? Technology coverage in remote areas, existing networks of frontline workers and community volunteers, or feedback from the communities. And we'll give you 1 minute to answer, and it'll come up as a percentage. Okay, just a few more seconds. Great. So 23% of you said technology coverage in remote areas. 64%, the overwhelming majority, existing network of frontline workers and community volunteers, and feedback from communities, 13%. The answer was existing network of frontline volunteers and frontline worker and community volunteers. Each of the projects that we heard from utilized those existing networks, built capacity within them to ensure that they were able to reach to the people on the ground, to the families that they were supporting. So good job. The next question. What was necessary to ensure the right support reached to families during lockdown? Integration of nutrition services and health facilities, training frontline workers, face-to-face counseling, family access to internet and smartphones. You can choose as many as you would like for this one. some common thread in each of the presentations that we saw. Great, just a few more seconds. Good job. So 67% of you answered integration of nutrition services in health facilities, 76% training of frontline health workers, 12% face-to-face counseling, and 79% family access to internet and smartphones. The integration of nutrition services in health facilities was incredibly important to all three, as was training to frontline health workers. We did see that in a couple of examples that having access to internet and smartphones wasn't necessarily a requirement to reach the families. They were used through SMS or telecounseling as well. So while internet access and smartphones was important, it wasn't dependent to reach the families. But great job. And that's the quiz over. I'm going to put now a survey in the chat box for everyone to complete when the session is over. So please watch out for that link. Thank you.
Thank you, Brooke. That was really interesting, and I wish we had more time to have more questions. So now I guess it's time to answer the questions that have been asked. So I'll hand over to Alex to walk us through the most commonly asked questions.
Yeah, thanks, Linda. Thanks to all obviously the presenters, but special thanks to the participants. There are extremely important questions. Unfortunately, we will not be able to discuss them all during this webinar, but rest assured, we will reach out to provide the answer for those that we are not able to answer now. Let me just ask one question to each lead presenter, maybe starting from Beam, if it's okay. There were very beautiful questions about your experience. Maybe Beam, briefly, a minute or a minute and a half. Can you elaborate a bit more on your virtual trainings, how they were conducted, how they were set up, how they were designed? Just a short answer, and then we can provide more information in writing. Over to you, Beam.
Thank you, Alice, for the questions. If I am hearing correctly, it is related with the training to frontline workers. Yeah, may I right? Yeah.
Yes, the online training, the remote training, the virtual training.
Because my connection is unstable, so maybe my voice will be the disconnect. Yeah. Regarding the capacity building to the frontline worker, first of all, we developed the training manual incorporate with the IYCF content, including in context of COVID, in collaboration and coordination with the government, which is called the Family Well Health Divisions. After that, we endorsed the manual and we did the training, build the capacity of the frontline workers and mid-level managers. We use the combined approach on the Zoom and virtual and the in-persons. And also, if there is not possible to do the virtual, those who don't have the modern technology, access of the modern technology, so that we did the in-person training in using the safety measures like using the masks, the compulsory hand washing before entry the event, and also social distance. So we use the combinations. I think it's in the short answer. It's okay.
Okay, thank you. It's very okay to start with, and again, to those interested, we will ask Beam to provide more details in writing, and so we can share it with the whole group. Thanks a lot, Beam, and thanks to your team. Let me go now to Ruba and the team of Ruba from the Jordan case. Again, there were several important questions for you, Ruba, but let me just bring out one of those. And there was a very interesting one actually about, from the presentation, the participant said, seems that the IYCF program is targeting only women, only mothers. And so the question is, are you also, what about men? What about the fathers? Are you engaging them as well? If yes, how? 1 minute and a half for you.
Okay, engagement of men and boys is important for us. What we do is that at the level of the shelter, whenever a mother receives an education session on IYCF for her child, a father is asked to remain set and listen to the session, and he is allowed to communicate and express his concerns. At the level of the support groups, we do have a support group for fathers and brothers, so that to identify the main issues they are concerned about, and to communicate the main practices that we observe at the level of the community to them, and to tell them how their influence affects the progress of IYCF among their families and households.
Fantastic, Ruba. And I'm sure it's just because the presentation had a shorter time, you couldn't present it, but that's a very important aspect of the program. Thanks again to your team, and other questions we will follow up with you so that you and the team can provide maybe a written answer. And let's go to Nazgul from the Kyrgyz Republic. I hope I pronounce it correctly. Nazgul, there were as well important question for you. I will only ask you one of those, but can you explain a bit more the role of the community health committee, and how you were able to engage with them? Just a minute or so about this, your engagement, the role and engagement of the community health committees. Over.
Thank you for the question. Village health committees is an existing union of community volunteers in country. They have a network of village health committees, VHCs, around 1,600. It's almost 85% of all villages in the country. And their membership includes motivated people who are able and willing to improve health in their communities. Their mission is sounds like to help people to be healthy. So we just engaged into the existing network by expanding their number. Usually they have 5 to 10 people in a village as a members, but we expanded and we recruited additional number of volunteers. We call them, and we work with existing activists and local village government together to engage more people. And after engaging, we train them on nutrition topics.
Thanks a lot, Nazgul. So again, unfortunately, we cannot ask you more questions live, but we will follow up so that you can provide more insights, and we will share it with all the participants. Conscious of time, and I better stop here, I'll give back the floor to Linda for the final wrap up. Take it, Linda, all yours.
Thank you, Alex. Thank you so much, Alex. Maybe I will take this opportunity to thank all the presenters and the team, the organizers, and the participants for hanging in there and really listening to these experiences. Now, it's really important to close properly, and therefore we would like to invite you to fill out now a quick survey that we are now sharing on the screen, and that I will allow the interpreters also to go through in order for you to fill it out. It's really important for us to understand, you know, your thoughts, but also your recommendations for improving such events and your needs in terms of contributing to improving programming experiences. So I will give a few minutes for you to click on the link that has now been shared in the chat box. And fill out this survey as we go through this final session. So I will give about 3 or 4 minutes for the interpreters to go through it. Ben, is there a way to enlarge a little bit the text? Yes, so maybe I can also go through it in English. So there's, of course, the information regarding the participant, and then a few questions about the material and some of the resources. So have you seen the WHO frequently asked questions on breastfeeding and COVID-19? If yes, have you disseminated or shared amongst your colleagues? Of course, this is important for us to understand the use of these products. And then have you, your team, or with partners adapted any of these resources, the FAQ? And then for which country? And then if yes, if you can tell us what were the major adaptations, the languages. And then if you would like to share comments and suggestions on how these FAQs could be improved. The next is about the UNICEF, USAID, IYCF in the context of COVID-19 counseling cards. Also a few questions about that. And whether you've used it. And we have seen, I think, one of the presentations that spoke about that. So hopefully we can expand on that and have more countries adapt these very important tools. And the language. And then, of course, at the end is whether there are any tools or SBC material that you think are needed, so that it can also help us with identifying gaps and then plan for any future material. All right, so I think this is enough time for the survey. I think we can now move to the closing of the session. I hope you enjoyed this Learning and Sharing Cafe. I would like to take the opportunity to thank all the partners, different organizations who are sharing their experiences, and really encourage everybody to, as we said before, how small or how large the program is or the experience is, it's really important for us to share in order for us to learn from each other. So last is, please take a few minutes to fill out the evaluation. As soon as we close the meeting, you will receive the link for the evaluation, and so it will take you just 5 minutes. I wish you a great rest of the day. There's some contact information here for TechRT that you can reach out to. Have a great rest of the day, and please join for the second cafe of this series, which will happen on Tuesday, I think it's the 26th of October, right? Or 27th, yes, 27th. Also, same time, where we'll also look at 3 more experiences. We are half past the hour, and I think we are on time. So thank you so much. Bye.
Thank you, Linda, to all.
Thank you.
Thank you.
Thanks.